A common question that I get asked about uterine anomalies is what is the difference between a uterine septum and a bicornuate uterus? I'm Dr. Lucky Sikon, a double board certified OBGYN and REI, here to answer all of your burning fertility questions. So let's get into it. Basically, a uterine septum and a bicornuate uterus are two different issues that can occur at different time points during the same process. So when we're a fetus in our mother's womb, our uterus, which is a single cavity, actually forms from two ducts that come up and join and fuse, and then there's this wall left behind, or a septum, that then gets resorbed, and that's how you get that triangular shaped single cavity called your uterus. So a bicornuate uterus is essentially a defect in that process that happens at the earliest stage. It's more of a fusion problem. There's incomplete fusion, so you actually end up with two horns of the uterus. It's almost like a heart shape. And the way to really understand if this is a bicornuate or a septum is to make sure you can look at the outer part of the uterus, which is one big thick muscle. And if the outer part is flat, but the inner part has that heart shape, then that's more like a septum. But if the outer part is part of the heart shape, it's really showing you that there's two ducts that didn't completely fuse. That is a bicornuate. There is nothing that I would do surgically or recommend in terms of trying to fix a bicornuate uterus. You just work with what you've got. And we know that because there's overall less space in each horn for an embryo to implant and grow into a pregnancy, there are higher rates of problems like preterm delivery in the second trimester or in the third trimester, and malpresentation, where you're more likely to have a fetus that's breech or not in the vertex position with the head down, so you're at a higher increased risk of needing a C-section at time of delivery. When it comes to a septum, that is happening later in this process. So you've already had complete fusion, but you just haven't had resorption of that wall. And it's just this fibrous tissue that has a lack of good blood supply. The main risk or association when it comes to a uterine septum, which is where you have a flat outer contour of the uterus muscle, and then you have this inner wall that often looks like an inverted triangle, is that it creates all of this extra surface area for an embryo to implant. But if that embryo implants on that fibrous wall, there isn't going to be enough blood supply to support it. So there is an association with recurrent first trimester miscarriages. And that's really the main way that it can manifest. It can also predispose someone to a higher chance of fetal malpresentation, like having your baby be breech and needing a C-section. So those are really the different ways that they can present. You can actually intervene when it comes to septum, because that fibrous tissue, you can go in with a hysteroscope, which is a long thin camera, and you can actually visualize, imagine the uterus as a big cave, right, like a big cavity, and you can see that it's divided in half. And you can sometimes get this double barrel view where you see two sides of the cavity in this fibrous wall, and it's actually a very satisfying surgery to do. You can just go in with scissors and kind of snip along it, and because there isn't a lot of blood supply, you can do this fairly easily, and you can actually see the cavity will kind of open up, and you've restored normal architecture of the uterus and reduced that person's chance of a future miscarriage. The last thing I'll say about uterine anomalies like septums and a bicornuate uterus is that the reason I wanted to do this video is that there's so much confusion about it, not just among patients, but I think also among some doctors, because I see patients who come to me and will tell me that they have one, and I'll discover that they actually have another. And that's because standard imaging, a pelvic ultrasound, isn't always going to clearly delineate the outer and the inner contour of the uterus. And you really need to see both in order to understand whether it's one or the other. So I typically like to look at a saline sonogram and get a 3D view of the uterus. And also I will usually send patients for a pelvic MRI to get more definition and really understand the anatomy, and also to see if there's any associated anomalies of the renal system, because some of those things can run together. So make sure, if you think you have one of these, that you're getting an accurate diagnosis and have a low threshold to get second opinion.